One testing. We're on. So I thought I didn't have much to talk about today, but I've got lots of questions, which is fantastic. I thought I was just going to talk about one thing, and then I've got loads of questions. But as ever, if anyone's got any questions, then please do ask away. Excuse me. I'm going to get straight right into this because if you want to know what this is what it is. It's a live Q&A with me, Jonathan Stoiano, consultant plastic surgeon. What's that? How often do I do it? Every Tuesday at 7 p.m. And what I'd like you to do is comment and share. If you've got any questions, comment away or ask away and share with your friends, I guess, or whoever you share things with. So we've got quite a few questions aujourd'hui. I'm going to talk about this because I said I would. How we organise theatre lists, because the thing that brought this up is because someone had to wait a long time yesterday for theatre, which is something I try and avoid doing these days. We try and bring you in quite. Don't leave you waiting on the ward when you're having surgery. We admit you. I'm not making this very clear. We try to admit you and then do the surgery quite soon after you get admitted, rather than leave you waiting a long time. I remember my dad had surgery and they brought him in at like 7 o'clock in the morning, and then they operated on it at 4 o'clock in the afternoon, and it was really bad. He's diabetic and everything as well. That was bad. He should have been. Anyway, so we try and avoid that, but sometimes people do have to wait, and someone had to wait yesterday, and I feel bad about it. She was fine with it, and I said I'd talk about it tonight, and she's like, I understand and everything. But anyway, I said I'd talk about it, so I better talk about it. So I'm going to talk about it. So this is me talking about it. So you might think, why do we do that? Why do we have to keep people waiting on the ward for hours? Why don't you just bring them in a couple of hours before the operation? And the reason why we do that is because the way the lists are organized. Now, if it's a local anesthetic list, if it's a list where it's just me or the surgeon and they're doing local anesthetic, you can bring people in just before the procedure, talk to them, and then do the procedure. It's no problem at all. So you shouldn't really have to wait that long if it's a local anesthetic list. The problem comes with it's a general anesthetic list. If it's a general anesthetic list and there's a theatre team and there's an anaesthetist involved, that's a different thing. Because what we do is we normally chat to you before the surgery. There may be some other things. Hi, Shona. There may be some other things we need to do. We chat to you, may need to do some photos, may need to do consent. The anaesthetists need to speak to you, so there's some things we need to do before we take you to theatre. And when there's a list with multiple patients, what the most efficient way of doing it is by bringing everybody in, and then me and the anaesthetist will see everybody, and then we go to theatre, we don't come out again. If you stagger the list, and sometimes we do stagger the list, and it's marginal whether we should have done on whenever it was Monday, but because if someone's going to be waiting a long time, you can stagger the list. You can ask them to come in at, say, midday if they're not going to have their surgery till 2 or 3 o'clock. The problem with doing that is if we go to theatre at 8 o'clock in the morning and we haven't seen that patient that's coming in at midday, what we have to do is we have to come out of theatre and then go and see them, mark, draw on them, talk to them, and then come back into theatre. Whereas when we're in theatre, we normally send for the next patient before we finish the operation. So as we come towards the end of the operation, we'll say send for the next patient, because the porter has to go and get the next patient, get them checked in, do all their checks, bring them to the anaesthetic room. And that can be happening while we're still finishing the last patient. If we have to do that halfway through the list, there's a delay in the list. The list sort of stops while me and the anaesthetist go out, because usually there's only one surgeon, one anaesthetist. If there's a few of you, like in the NHS, often you have a team of people and lots of other doctors involved, and one of the other doctors could go and see the patient, then you could do it that way. But in the private sector, it's very much consultant-led, so it's usually just a consultant anaesthetist, consultant surgeon. And so it's much more efficient to see everybody before you start the list. And then the way we structure the list is, personally, I usually do the smaller cases first, because that way you're for two reasons. First of all, you're leaving people waiting less if you do the quicker cases first and then you leave the longer cases to the end. Also, if you've got a longer case, you really don't want to be doing another surgery after the long case. So you try and do, or I try and do the smaller cases first, and then to try and minimize the wait time. So if you've got 2 1-hour operations and 1 3-hour operation, rather than doing the 3-hour one first, in which case the other 2 have to wait 3 hours, or one has to wait 4 hours, you do the 2 1-hour ones. So then one person has to wait 1 hour, one person has to wait 2 hours. Need a graph of this, really. Oh, that's clear. Anyway, that's the reason. So sometimes you do have to wait. But as I say, it was marginal on Monday whether we should have staggered it a bit. But because I do feel a bit bad about the wait, especially in this heat and everything. But that's why we do it. We're not trying to be mean. We're not trying to keep you keep you waiting for hours. But it does make the list run much more efficiently if we see everyone before we start. But if you have got an all-day list, I think there is an argument to say to bring some of the people in later. Right, thanks, Jenny. You get it right. Okay. So thought I'd explain myself. Right. So we've also got. Am I going to do this in order? I'm going to do it in order. Here we go. How to reduce swelling after liposuction and tummy tuck. So basically, I think this is 2 separate things, but I think they're linked together. So one of the big things about liposuction, and I see this all the time. I had a patient the other day who had some surgery, and there is always swelling. Liposuction is quite traumatic. Liposuction looks quite benign because the incisions are quite small, and you think, oh, I can't see that you've had anything done from a scar point of view, but it is quite traumatic. I don't know if you've ever seen it. I'm sure it's all over YouTube if you want to see it, but it is quite a traumatic thing. So you do get quite a lot of swelling afterwards. So sometimes you have to try and manage the expectations of patients and to speak to patients beforehand to make it clear that when you have liposuction, sometimes it can look the same or maybe even worse than what it looked like before. You think, my Lord, I spent all this money on liposuction. Look at me, I'm looking worse than how I looked pre-op. But that is obviously swelling, and the swelling will go down. Right? What you had before was fat, and the fat won't. Well, it will go down if you lose weight, but it's not going to go down on its own. So there is swelling after liposuction. How you reduce swelling now? Compression is good if it's an area where you can compress. So for instance, it's on your hips, your thighs, you can wear a compression garment. On your chest, like male chest particularly, you can wear a compression garment. So on those areas where you can get compression can be good. Some areas it's more difficult to get compression around the knees and things. It can be difficult because you have to wear quite long garments, so it can be difficult, particularly if you're crossing a joint with a garment. It can make the garment quite uncomfortable, but compression is good. The main thing I say to people is it is traumatic and it is going to swell, and compression can manage that. But you have to admit, you have to accept that your body has been knocked about a bit and there will be swelling and it will subside. Some people talk about heat or ice to help with the swelling. You have to be a bit careful with that, because when you've done liposuction, often the sensitivity is altered. In that it can feel a bit weird, feel a bit strange. So you've got to be a bit careful putting hot and cold on it, because it can you can burn the skin without knowing it, because the sensation can be altered. So just if you are going to use anything cold, wrap it in a towel and things like that, and just put your hand down there to check the skin's not getting too cold. I don't particularly recommend those things. I think the main thing is rest. Elevation, if it's on something that you can elevate. Going about the tummy tuck, I think this is particularly, and this is someone's just asked on Facebook, but also someone asked me this morning about this, about the tummy tuck in this weather. What do you do in this weather? And it is a bit of a nightmare in this weather, having surgery and compression, and things are going to swell, and how do you manage that in this weather? And it's really difficult. I haven't got any good answers to that, and I think the compression does help. So certainly for a tummy tuck, I think the garment does help for reducing the swelling of that area. When you're having breast surgery, I often use tapes on that and can give you a bra. The bra is sort of like a garment, but you can avoid wearing the bra to start with, or sometimes people will like wearing the bra on top. I would just say I think the compression garment is good. So I think maybe what they're saying to me is, do you not have to wear the compression garment? I think you should carry on with the compression garment, really, because I think it does help with the swelling. But you can take it off for periods of time, and also the rest of your clothes you can, maybe not wear much else. I think it is good to take it off every now and then to let your skin breathe. You don't want to get hot and sweaty and get rashes and what have you. But I think cool stuff can help, like ice, as I say, but wrapped in tea towels. I haven't really got any good answers for this question. I did say what's a good thing to do in this weather? I don't know. Air conditioning. It's just a bit difficult in this weather to have surgery, I think, and I think you just have to manage the compression as well as you can. I haven't answered that very well, have I? Yeah, just manage the compression as well as you can, but persevere with compression. And as I say, it swells with everybody. It's going to swell a bit, and just accept that it will swell, and you just have to manage that as well as you can. You're going to get to the same end point. It's just getting you there in the most comfortable way. Okay. Hope that's been helpful. Feel free to comment if it hasn't been helpful, and come back at me. Come back at me. Make me answer it better. Next. Self-harm scars. We get this a lot. We've got someone this week who's got this issue, and this is tricky. And the patient that's got in touch recently has got some well-healed, obviously very old self-harm scars from a different period in their life, and now has a job and everything and wants something done about it, and it's really difficult. And it's really difficult to do. This sort of goes back to scar revision, really. What can you do to revise a scar? Because as surgeons, we just give scars. And the scars that this patient has got, they've got some scars in the lower part, some scars in the upper part of the arm. Certainly the scars in the lower part of the arm are just well healed. They're faded. They're good scars as scars go. The problem is the stigma attached with the orientation of the scar. And if you have multiple scars in a sort of transverse orientation, on the the inner aspect of your of your wrist, it's associated with self-harm, and so surgically the scars higher up are a bit stretched. They haven't been treated. So often with self-harm scars, people don't go to doctors or don't go to the hospitals to have them treated and just put a dressing on them. So they often end up a bit wide. These are a bit puffy. So when you bend the arm, it puffs out a bit. So the more proximal ones we could revise by making them less wide, less stretched, maybe less puffy when you move your arm, but there'll still be a scar. It might be a better scar, but there'll still be a scar, and the stigma might still be there. Probably the best thing and it'll be a fresh scar as well, which will then take 6-12 months for it to settle. Probably the best thing, really, the best answer I've got, which may or may not be a good answer, is camouflage makeup, cosmetic camouflage makeup, which is great for a lot of things because these scars are flat, they're not raised, and they're actually good scars. The problem with cosmetic camouflage makeup, it can be a bit uncomfortable to wear. Again, in this weather, it can be a bit grim because it can be hot and it can, be uncomfortable. So it may not be a long-term solution. It may not be an everyday solution, but if you're going out or if you're doing something where it's important to you to have it covered up, I think that's probably the best option. And surgically, as I say, it's for a well-healed, pale, thin scar, it's hard to make that better with surgery. If it's wide, if it's bulging, if it's lumpy, there are things we can do to help with those things. But often, certainly after a few years, these scars have settled and matured, and it's very hard to do anything about it. People think to take them off and skin graft and things. Skin grafts don't look good. They really don't look good. I think people have the perception that skin graft looks like normal skin. It doesn't, and it's not really a good option for these multiple self-harm scars, and I don't think that's a good option, and I think that would potentially look worse, having a skin graft on your forearm, because it is a cosmetically sensitive area. So there's no real good options for self-harm scars, and it's really just covering it up if you can with cosmetic makeup. I think it's probably the best option, which is not something we really do at the clinic. I think you'd have to, but you could give us some Vicky then. Might have an idea about where to go for that, but that's something you have to seek help elsewhere for. Wow, that's come out big. Why does that come out big and the other small? Sun protection and scars. Sun protection, full stop, forget scars, is very important, and we tend to think of it in this time of year, and we make sure our children have got sun cream on, and we make sure we've got sun cream on this time of year. But Donetta's in the house. Oop. Hi, Donetta. I guess what those are. Those are what those eyes are. There they are. See, I'm looking around. So sun protection and scars. Yeah, well, sun protection anyway. I think we all need to look out for sun protection, and we need to really, for some reason, sun protection hasn't really caught on. I don't know if I've spoken about this before, but there's a lot of things that have caught on. Toothbrushing. We brush our teeth every day, don't we? Twice a day. That's really caught on well. I'm really impressed with how the drink driving or lack of drink driving, that's really caught on really well. Smoking in public places, that's plastic bags. There's a lot of things that are caught on and that we've sort of embraced as a society, but sun protection isn't one of them. I don't really know how we get things to catch on, but it's quite impressive how these other things have caught on, but sun protection hasn't. Sun protection is really important, and we really should be thinking about sunblock really on a daily basis, not just when it's sunny, not just when you get worried about getting sunburnt. We should really be protecting our skin from the sun's radiation all the time, but it's not really something that we do, is it? So sun protection is important all the time, but particularly sun protection and scars, which is what this is asking about. So answer the question. Okay, all right, calm down. Sun protection and scars. Got to be careful with scars when they're red and active. So scars are red and active. It's variable how long it takes scars to fade. I normally say to people, scars start to fade around 3 months. They can take 6, 12, 18 months for them to fade. That's what I sort of say as a general terms for any scar anywhere. Some parts of the body scar better than others. The face tends to scar well. The back and the leg don't scar quite so well. So there are certain locations which scar better than others. But as a general rule, things start to settle and fade around 3 months, but it can take longer. Some to 8 months, 10 months are still very red and active. And while it's red and active, while the scar is still red, if you get a tan on that scar, it will pick up the tan and it won't lose the tan. So you'll end up with a pigmented scar. So your rest of your body will lose the tan, but the scar won't. So don't get a tan on your scar while it is red and active is the basic advice. So that means where you've got an active scar, which is up to the first sort of 6, maybe even 12 months after the surgery, don't get a tan on it. So sunblock, which means sun protection or tape or clothing, cover it up. Just don't get a tan on it. You should be fine. So yeah. So, I mean, I saw someone today, didn't I? Yes, I did. Talk to myself. Who is going on holiday in a couple of weeks. I think he's going on holiday. Anyway, he's got this thing that would have left a scar and, wanted to get it done before. And I'm like, I think you're better off going on holiday. Enjoy your holiday, get a tan. You can do whatever you want, play at the beach and everything, and then come back after your holiday and get it done, because it's just going to be a real pain if you've got a red scar and you're worried about it and you put tape over it and then you get a suntan mark with the tape and you go in the sea and the tape falls off and you think, oh my God, you're swimming and worried to get a tan. So yeah, this time of year is not a good time of year for lesions on the face and things like that, because you've got to worry about the sun on them. But if you do have a scar at this time of year and it's red and active, don't get a tan on it. Cover it up, or sunblock or tape. Buonasera, Anna. Good to see you. Always good to see you here. What we got now, we got a question about VASER liposuction. That's another big one. I don't know why they come out big sometimes. Can't answer that. I don't make the font sizes. I'm not in charge of font sizes. I like the big. I'm liking the big. VASER. So we've had, we've had some questions. That's a funny face, isn't it? Anyway, we've had some questions about VASER this week. I say some. I think we've had more than one. Have we? I don't really know. Vicky told me we've had some. Anyway, got no reason to disbelieve her. We get periodically questions about VASER. People are asking about VASER. Now, the bottom line is I don't do VASER. So I'm very happy to talk about it, but I don't do it. And I think this is one of the things, this leads on to a wider thing about talking about things that you don't do, which exist. So I do tell people about VASER. It's a bit like polyurethane implants. People don't talk about polyurethane implants because they don't do them. I think everyone should be told about things, whether or not they do them. In fact, it's good medical practice. It's something we're advised to do. We need to tell patients all the options, whether or not we do those options. So VASER is an option for liposuction. There's different types of liposuction. VASER is one type. It is an assisted form of liposuction assisted with ultrasound, and the ultrasound energy sort of provides energy to the fat, which destroys the fat before it is sucked out with the liposuction. And the good thing about VASER is that because the ultrasound is destroying the fat before sucking it out, you can use a smaller cannula. So the cannulas are smaller with VASER. You can often do it under a local anesthetic, maybe with sedation, but you can do it's sort of less traumatic because, as I say, the cannula is smaller. And because it heats up the fat, they do say that it causes some degree of skin retraction, which is a good thing, but certainly for areas like the tummy. So VASER is a good thing in those terms. I don't do it. The reason being that, number one, I haven't really seen the need for it. I think if you speak to doctors who do a lot of VASER, they will tell you that probably you can do anything with VASER. You can do things with, how can I put this? Anything you can do with VASER, you can do with normal liposuction. I do normal liposuction. I do what's called power assisted liposuction, which means the machine moves backwards and forwards. But it's basically tumescent or power assisted liposuction. It's not assisted by ultrasound or any other sort of energy device. There's also laser assisted liposuction, which isn't VASER, a bit confusing. VASER's ultrasound. Laser assisted is stuff like smart lipo. They sort of provide energy to the fat before you suck it out. I don't do them because I don't feel the need to do them, because I think I can get as good results with power assisted liposuction, although I have to say that they do say that it causes some skin retraction. So certainly for the tummy, some areas like the tummy and the inner thighs, I'm a bit more reluctant to do liposuction because it doesn't give that skin retraction. That's where sort of tummy tucks and thigh lifts come in. But VASER might help, and I normally say to people, look at people who do VASER, look at their before and after photos, see if you think that they can give you the result you want, because that might be an option. So you could argue that I should be doing it if it does help those areas, but I don't, and I don't offer it because we don't have the machine. I think the machine costs a lot of money, and as I say, I can get the results I need with a power assisted liposuction. And I think there is an element of sort of marketing in terms of the VASER. I think that, and it obviously works because a lot of people inquire to us to say, oh, they think it's good. And I don't think it isn't good, but it's not something we do. But so you need to seek someone who does it. And I think it has got some good things about it. But look at some before and afters to see if you're going to use it specifically for things like the skin tightening. Just look to see if it's enough to warrant it. Because in my experience, you can do a lot with power-assisted liposuction, and arguably you can do as much with power-assisted as you can with VASER, although obviously the people who make VASER might disagree with that. So you better see them, because they you could argue I'm giving a biased opinion because I don't use it. I'm trying not to, trying to give you a level opinion, but yeah, that's the answer. Look at people who do VASER, and it's certainly something that's out there and something on offer. So it's something to take into consideration if you think you're having liposuction. It's a thing. What else is that? Let's go. B-Lite. Right, patient has inquired this evening recently, not that long ago, and she's asked about B-Lite implants. And B-Lite implants are implants. I've got it at the clinic there. They're lighter, 30% lighter than standard implants, and they're new and they're great. And I think they're a really good thing. And it's something that we spoke about years ago. It was talked about years ago, making an implant that's lighter. And it was I was on the advisory panel of one of the implant manufacturers at the time, and all the surgeons from all over the world there, and we all said, really good idea, fantastic idea. And now it's here, B-Lite implant. So I think it's a really good idea. And if anyone wants to consider them, they're welcome to come and we can talk about it. This patient said, I can't remember what she said now, but she was asking about what experience we've got and how many we've done and what have you. We haven't done any. So you might think, oh, I have been offering them for a while, but I don't really push them, to be honest with you. And the reason I don't push them is because they're new. And I've written a blog post about this. And unfortunately, well, not unfortunately, you find doctors are quite risk averse, and we're quite worried about new things. And because they're new, we don't, really know what the benefit will be. They're more expensive than normal implants, so there is a cost implication because they are quite expensive, quite a bit more expensive than a standard implant. And I feel that the real benefit will come in for the bigger sizes. I think that's where really the benefit comes in. We don't tend to do like the really big sizes really at the clinic. We really tend to see more people who have maybe lost weight, people who had children, mums with children, things like that, unhappy with the breast. They want something more in proportion rather than doing the sort of really big implant sizes. So that's not something that we see a lot of at the clinic. So maybe that's why. I don't really know why we haven't done any. I'm happy to do them, but as I say, I don't really push them. Because it is new and because you always worry with any new technology. I mean, it's got a CE mark, it's approved to be used in this country. But as I say, I guess the main things are it's expensive and it's really for the bigger sizes that it comes in. For the smaller sizes, the benefit I think is a bit more marginal, I think. But, really it's, again, up to giving patients choice. But again, they're there, they exist, and they're something that you could consider if you thought it might be beneficial to you. But I said I'd talk about it here just because someone was inquiring earlier. And I think it looks bad when you say you haven't done any. But I got no qualm. We're not going to sort of try and tell people we've done stuff when we haven't, or that we do this or that. Be very open and honest about what we do. We mainly do breast surgery at the clinic. Breast and body is most of the surgery. So we do a lot of implants. And B-Lites are out there. Whether they're going to take on and be really popular in the future, I don't know. But I think at the moment you'll find a lot of plastic surgeons are a bit, I talk to my colleagues and I think we're all a bit anxious about them, to be honest with you. And that might come through when patients talk about it. You might find that we're more comfortable talking about the implants we've been using for the last 10 years. If you've been using implants for the last 10, God, I don't even want to think, maybe even 20 years, and you're familiar with them, then a new implant comes in. Do you really want to start working with them? Unless there's a significant benefit, I think you'll find that a lot of us are a bit risk averse. So again, I think it's about advising patients, letting patients do the research, and just offering things. And if they think it's right for them, then that's fine. So I thought I had loads of questions. That's it. I'm out of questions. I thought I'm going to get through these really quickly because I'm going to be here all night. But that's it. I hope I answered them all right. I don't know. Did I have to look back on that? Reflect. Some tricky questions tonight, I've got to say. How do you manage swelling in this heat? That's a tricky one. Come on. What else do we have? The self-harm scars, really hard. I feel like I've needed to get... I don't know if I've answered any of them very well, but I try my best. I can do no more. I hope that's been helpful. We're going to have dinner now. So I'm going to check out now. Checking out. And I'm going to, without further ado, I'll see you next week, 7:00. Any questions, get them in. Maybe do a bit more research next time and answer those ones better. Oh, someone's coming. And I will see you next week, 7:00. Bye. You just missed it.